along with our CDH convener, Dr. Pradeep. He organized a lot of vaccination camps, and a lot of members were calling us to get the help from them in getting admissions during that COVID situations to various hospitals, or getting that oxygen, and recently for that amphotericin B. So silently, the office bearers of Madurai branch, they worked like anything, and they have helped a lot of members of our branch, also from that non-members, to make that situation little bit comfortable. So I think with these few words, I welcome all the members, all the branch members, and all the branch eminent personalities of various other branches to this particular webinar. And I just hand out that to Dr. Arularasu. Thank you. Man.
Thank you, Gururaj sir. Since it's the day of Dr. Swami Vivekananda, I would start with brothers and sisters of India. And hello, can you hear me?
We can. Yes, sir. Yes, sir. We can hear you.
Yes, we can hear. We can hear you.
Yeah, since the day of Swami Vivekananda, let me start with brothers and sisters of India and our fraternity. A warm good morning for everybody. It's been a tough year since the year. I think everything eases up in the forthcoming year. We welcome you all for the first webinar program organized by IDA Madurai and Mani. And I'm happy to say that we have participants from Kerala also. I think Dr. Loji from Kerala is there with us. And we have participants from all around the state. I'm very happy to have such a good number. Anyway, personal thanks to Dr. Vinod sir for being the speaker. I hope he's going to have a brainstorming session. Thank you to Mani. I think I will let the Mani team to introduce themselves. Thank you.
Thank you, Dr. Arul. And on behalf of Team Money, I thank the entire team of IDA Madurai for giving us this opportunity to conduct this webinar along in association with such an efficient team. And before we start, just a quick introduction about Money Company that I would like to share with all. Just a second.
Sir, Zoom இல்லைங்க சார், நீங்க இது Zoom கிடையாது, இது routine Zoomல இல்ல சார், நீங்க டைரக்டா கிளிக் பண்ணுங்க தயவு செஞ்சு.
I hope my screen is visible to all.
Yes, it is.
Yes, sir.
Great, thank you.
Yes, go ahead, boss.
Thank you. So my name is Shivam Sai. I'm currently working as a marketing manager with Money Medical India. Money as a company was established in the year 1959. And since then, we have been manufacturing and providing high-grade dental instruments, ophthalmic instruments, and general surgery instruments across 120 countries worldwide. The name of the company was taken from the name of our founder, Mr. Masao Matsutani. We took the first two letters and the last two letters of his last name and formed the word money. This is the list of consolidated subsidiaries that Money Incorporation Japan has across the globe. And the latest addition to this list is Money Medical India Private Limited, and we are based at New Delhi area. These are the glimpses of a few of our factories and offices. This is the main headquarters in Japan in the Tochigi state. And these are the factories from which the world-class equipments are manufactured and supplied across the globe. When we talk about Money Medical India as an organization, we have our managing director, Shingo Kuriyama-san, who heads the operations in India. Then we have our vice president, Mr. Ritesh Sharma, who is joining us on the call today. And along with that, we have an entire team of well-educated and scientifically trained team members, those who are there in the field supporting all the doctors day in, day out. The basic business policy that Money has always believed is that the best quality in the world to the world, as we believe that everyone in the world deserves the best and we are capable of delivering it to every corner. We invest 9% of our revenue into R&D continuously, and currently we hold more than 433 patent rights. Money as a company is not only into dental, we are there into surgical instrument also. We prepare eyeless needle. Talking about surgical instruments, we have our ophthalmic knives, we have ophthalmic switches, we have skin staplers, we have eyed and eyeless needles. And just to show you a glimpse of what money technology is all about, if you can see, this is the size of needle, which is less than 140 micron, and money has the technology to prepare a hole at the top of this needle. So that is the kind of technology with which money as a company works. Coming to our dental instruments, we are into rotary instruments. We have our retreatment instruments. The dental switches and needle will be introduced soon in the India market. Plus, we have our hand files, our pluggers, and root canal instrument systems. Our offices and factories from which the world-class equipments are prepared, they are all ISO certified, they are FDA registered, and CE registered. Countermeasure against counterfeit products. Now, we all know that money products have been available in India from more than 2 decades. But in past, there have been an issue that a lot of duplicate products were being floated into the market. And to counter those counterfeit products, Money Medical India came into existence in 2017. And since then, we have been running awareness program all over the country. Whenever we were doing the on-site workshops, we share these details with all the doctors, those who are in presence, that these are the from where to purchase, who are the right dealer and distributor channel which are there on Money, and you can get original products from them. Along with that, we also have these check filter that have been provided to Money authorized distributor and dealer network across India. Now, whenever you're ordering your products and your dealer or distributor is hand delivering the products, and if he is a Money authorized dealer, you can ask him to bring this check filter along with him. This check filter has two sides. The yellow side is used to check the authenticity of a diaber strip, and the green and red side is used to check the authenticity of a file of money file pack. Now, at the back of a diaber strip, if you see there is a silver strip which has been placed on it. When you place that strip under this filter, this is a small window which is there. It has a no, small film pasted in it. When you see that strip beneath this, you'll see the text OK coming up and the color changing dark to one side. But in a case of duplicate strip, that will not happen. So this is how you can check the authenticity of a diaber strip. When you talk about a pack of file, at the back of the pack of file, there is a Money logo. If you see that Money logo under this filter, the color of the logo will be corresponding to the color of the filter. The red side will have red color, the green side will have green color. So in case of a duplicate pack, this will not happen. So these are few checks that you can do when the distributor or the dealer is hand delivering the products to your clinic. In case if the distributor is couriering the product to your clinics because it's too far away, he's not able to hand deliver it, then the additional checks that he can do is, first thing, all Money products come with an MRP logo on it. It'll have an MRP sticker pasted on it. We will not sell any product without an MRP sticker. Plus, our products will not have any such shiny round stickers placed on it saying that genuine products or 100% original quality or something of that sort, because we as company know that we are providing the genuine products in the market. So these are some additional steps that you can do while making your next purchases. Now, quickly, just like to update you that we have our website on which you can go and check all the product details. You can get all the product information from there. Plus, we are also available on social media. We request all the attendees to follow these handles. On these social media sites, we keep on updating about our product features and benefits, the promotional campaigns that we are running currently. Plus, we also keep on updating the next webinars that we will be conducting. So through this page, you can get all the updates from Money. Just a glimpse of latest products that Money has got into the market. We have got the depth marker diabers for your veneer preparations now. We have the Money endo holder and microfiles that are available in the market. We have the contra-angle diabers which are there. We have the diabers on supercores, which are black band diabers, which are used for mass reduction and cutting your zirconia crowns. We have safe and diabers in the market. We have diabers specifically designed for pedo patients, for your pediatric patients. We have the long shank carbide burrs, which is 28 mm in total length. Plus, we have a safe and carbide burr also for making your palatal walls, cavity wall. For enlarging your cavity walls. We have the metal cutting carbide burrs. And recently, we have introduced the restorative range of products. We have the best quality bonding agent. We have the resin composites. We have luting cements, and there will be many more that will be coming in near future. These restorative products are fashioned by a combination of Japanese standards and German technology, and now they are available in India by Money. This is the entire range of Money composites and bond that we currently have, and soon we will be introducing more in this segment. This is the list of entire team that we have across our nation. You can keep a note of these numbers and people. You can contact them for further inquiries about Money products, and also you can contact them for placing orders. So with that, I would like to end my presentation and would request Dr. Sujata to please take over. Thank you.
Shivam, can you allow me to share my presentation?
So you can already.
Okay. Are you able to see my screen?
Not yet, sir.
I think so. There's some
Yes, sir, it's coming up.
disturbance in the mic.
So we can see your screen.
Vinod, go ahead.
There's some disturbance here on the line. Shivam?
Sir,
Yes,
Dr.
sir.
Vinod.
Yeah, sir. Please go ahead. Can you all hear me?
Yes, sir, we can hear you.
Yeah. Is there any other proceedings or can we start?
Sure. We will, Dr. Vinod, we will just give you a speaker introduction for you, please.
Just before we start with the program of Dr. Vinod, I would like to introduce to all the participants our speaker for today. I'm really overwhelmed to introduce to you all our speaker for today, Dr. Vinod Kumar from my hometown, Bangalore. Namaskara, sir. Dr. Vinod graduated from Bapuji Dental College and Hospital, Davangere in the year 1999 and completed his master's in GDC Bangalore in conservative dentistry and endodontics in the year 2002. He was the professor and head at the Sharavati Dental College, Shimoga. Currently, he is the founder and the CEO of the Dental Health Organization, which has developed India's first digital dental platform to organize dentistry and dental practice in India. He is one of the pioneers to introduce the nickel titanium rotary instrumentation, thermoplastic GP techniques, and micro dentistry in India. He has been a guest speaker in numerous national and international conferences and has conducted various hands-on programs or courses on rotary endodontics. He has been invited as a guest speaker in Academy of Microscope Enhanced Dentistry in 2011 in Texas. He introduced a novel concept of cleaning and the smear layer from the root canals called the whirlpool effect. He has numerous publications and case reports to his credit and conducts live demonstration in using microscope on root canal treatment and periapical surgeries. And last but not the least, I think so, Dr. Vivek Kumar has his own YouTube channel, and I've seen his YouTube channel, and a lot of subscribers also are present. I saw that his video of the whirlpool effect. And Dr. Vinod, am I right about it?
Thank you. Yeah, that's right.
Welcome you, sir. I think so. You can start with your management of complicated root canals by new nickel titanium files, sir. Thank you.
Thank you, Doctor, so much, and thank you, IDA Madurai branch, the president, the whole team, and Dr. Arul Thank you for inviting me, and thank you, Mani Medical, Ritesh, Shivam, Manoj, and everyone else who are present today. So when a topic is given to me, I always like to ask, what does the audience want? So what has happened is there is always curiosity for all of us to know what is an endodontics. Endodontics is such a subject. It looks easy, but it is difficult to master. So in this, when I was given this topic and I said, what shall we do? So I've decided this management of complicated root canals. But in my presentation, you're open to ask me any questions related to endodontist, but I will try to focus on one aspect of endodontics today, but we'll have the question and answer session, which will be open in a more broader sense. I request Dr. Sujata to moderate this session for me. Is that okay, Doc? Are you there?
Yes, sir. Yes, sir. Sure, sir. I'm there.
So I just wanted to ask few questions to anyone in the audience today, that what interested you to join this particular webinar today? See, there are many webinars conducted by many people across the country. Everybody talks about endodontics. Endodontics is something which everybody loves because that's the bread butter. Patient comes to us only when they have pain. Anybody who can just share that what they want to learn in one or two questions, I can just get in a nutshell. Dr. Sujata, anybody?
I think so. The basic thing what everybody wanted to know is how to avoid this failure of this root canal survey. Almost for the first 2 years, it is like very nice. After the 4th or 5th year, we get back patients, and we see a lot of micro leakage also. And because of this, there is failure of root canals. So I think so most of our participants are interested in knowing how we can avoid all these micro leakages and avoid the failure of root canals and all those things, sir.
Okay, great. So,
sir,
yeah.
1 second, sir. I want to learn for the access cavity preparation, how not to disturb the dentinal map. That is the very important thing in endodontics. Am I right, sir? If we have
Perfect.
time, kindly share your knowledge on that.
No, I will go through when I'm actually presenting my slides. We will touch upon all these points. But I want to know one interesting thing what Dr. Sujata brought upon was a very interesting query, because all of us are scared that what will happen the next moment after you finish the root canal. How long will it last? So what I understand is everybody is looking for success in root canal therapy, or any treatment we do in dentistry. So let's base our topic today, or the whole specialty discussion, based on how not to have failures. Okay, I think that's an interesting note to start with. So greetings from Bangalore to all of you. I come from this beautiful city, garden city, but which is not still garden city anymore, but we have a lot of concrete jungle happening here as well. But we get to see these beautiful flowers in the Cubbon Park, which is in the heart of the city. So I just thought I'll share this. So you must have seen in my introduction, apart from being a clinician, I've also tried to be a marketing person for dental profession by and large. So IDA is great. It is an association, but we need a company to run. So I'm a dental startup. So we are launching the dental insurance for the first time in the country in the next few months, or maybe in the next year. Because of the pandemic, we have delayed. Without the insurance, the dental industry cannot be organized. So that's in something you can look into my website, which is called as dhoindia.com, for more details. Run through all these things. What exactly today we are going to focus on these three points is that we all know what is an access cavity, we all know what is biomechanical preparation, and we all know obturation. But today my presentation will focus on something called as biomechanical preparation, so which will help us to understanding endodontics in better way. We are talking about nickel-titanium rotary files, which focuses on this part of the triad. But what I want to emphasize is that for the failure and success, as Dr. Sujata rightly suggested, everybody wants success. So what is that which needs, the tools which needs our endodontic therapy to be successful is one, coronal restoration. The coronal restoration, why I'm stressing so much is as all of us after obturation, we give a temporary filling and send the patient, thinking that the patient could have pain, and then we can call the patient again and open our obturation and see if there is a problem. Please don't do this. And intermediate dressing also should never be done with temporary fillings. And I will suggest that you always rely on glass enamel as your intermediary restoration and also the final restoration. So moving on to the next slide, as I mentioned to you, I'll be focusing my presentation
presentation today, and I'll take the questions on endodontics as a whole after the presentation. Which rotary file do you think was used to prepare this tooth? Anybody looking at the radiograph, can you suggest that which rotary file was used to prepare this particular tooth? Dr. Sujata, what rotary files do you all use in Madurai? What is the rotary file which is commonly used in Madurai?
ProTaper file, sir.
Dense ply ProTaper.
So do you all think that your ProTaper files could do this? Have anybody prepared using a ProTaper file to maintain this curvature?
You can use that raised type of files, sir.
So you're all thinking of files only. Files means endodontics was born just now when the rotary files began. No, this was done by one Dr. Johnson, who coined the terminology in 1939. He never had any rotary files. He never even had stainless steel files. But those days, what files were available were simple carbon steel files. Okay, the nickel stainless steel files came into dentistry only in 1940s and above. So this was prepared by a dentist. What I want to emphasize here, why I brought this slide on the first place, is to tell you that the dentist and the clinician, you and me, are more important and not the file system. The knowledge of the canal anatomy, before even calling it as a complication, if you know the knowledge of the canal anatomy, what is the problem with this canal, why this canal cannot be prepared or shaped, what are the instruments used, the knowledge of the anatomy is the priority thing and not the rotary files. Okay, is that clear? Do you understand that you should know the anatomy as the major factor before doing your endodontic procedures? So if you see this, I am showing a file. This was treated by the newly launched rotary file. What I like about this file is that I'm able to maintain the canal anatomy as it is. If I look at my pre-op radiograph, I cannot maintain the canal. I do not know what is the canal anatomy because it's very vague. I do not have a three-dimensional picture like a CT scan to evaluate. And today, endodontic procedure itself, the patients call it as an expensive. Rather than you asking them to go get a CBCT done for their endodontic procedure and then evaluating, no, I will teach you the simple clinical skills and techniques to evaluate the curvatures, how difficult the curvature could be, how much, which rotary file should be used, and that is what is the key presentation today. So we are talking about management of these complicated root canals. There is, all the root canals are complicated. There is nothing called as an easy root canal or a difficult. All root canals by default are complicated. It is how you assess them, what is the level of complexity matters. Is that clear? For this, I owe this, kind of preparation maintenance of the canal anatomy to the JIZAI files. They're able to conservatively manage the canal, yet not unwantedly shape the canal anatomy just for me to take it to the apex. It is almost a 90-degree curvature, which is well maintained, and the curvature almost starts at the middle 1/3 of the canal. If you look at my previous x-rays, the curvature is only at the apical 1/3. Okay, the apical 1/3 curvatures are easy to manage, but a curvature which starts at the middle of the canal is much difficult to handle. And I will tell you why when we are moving to the next few slides. So what do you call it as a complicated root canal is that any posterior teeth is a complicated for me, right? Do you all agree? Dr. Sujata, any posterior tooth, you call it as a complicated. Yes?
Yes, sir. That's what generally everybody thinks.
Yeah. The other complication is curved canals. Let's first of all define what is curved canals. All the canals are curved, but where the curvature starts matter, whether the curvature starts at the coronal 1/3, middle 1/3, or at the apical 1/3. Coming to the calcified canals, because of the invent of composite restorations these days, if you look at a tooth which is filled by amalgam, the canals are much patent, right? But when you look at the teeth which was just filled 6 months back with a composite restoration, and a young patient who walks inside your clinic with a severe pain for a composite restoration, you open up that tooth, you feel the canal is calcified and the canal looks like a 60-year-old patient's canal. Have you all observed this?
Yes, sir. Yes, sir.
You should know the reason why this happens. So the composite tries to create some kind of inflammatory process to the pulpal area. That's the reason composite should never be used in deeper pulpal cavities. So it will lead to definitely absorption of water and creating an inflammatory response, which starts a calcification process in a very funny manner. You mean to say that if you open up a canal, you will see the coronal orifice itself is not easy to go through. And the canal calcification patterns in a composite treated tooth is very unique, that the pattern is not uniform. The calcification is not uniform. There's somewhere stops, the file is not going even at the coronal area, then you'll have to use some other technique to open up. The other common complicated problem is the missed root canal. Like one of the doctors before my presentation asked me how to identify MB2s. So when it comes to MB2s, all the teeth close to that too, with a Dravidian population or a South Indian population, the incidence of MB2s is more than 73%. Why we are lucky is that even if you're not obturated, MB2 is not a main canal. So if you look at this picture, you have an MB1 which just goes here. The MB2 usually goes and joins the MB1. So that's the reason, though you are not able to fill and obturate the MB2 or even identify it, since the main canal is an MB1, it doesn't totally exit to the what you call separately like this. It goes and joins. So you're lucky that you don't get into complications. And of course, most of the patients today want to save their teeth. Third molars, usually 7s are extracted. So third molars are used for a good bridge preparation or anything. And the other complicated root canal anatomy of in the oral cavity is from the lower premolars, which is very challenging to treat. Mostly the bifurcations and trifurcations happen in the apical area. And finally, coming to retreatment. So hope I have included all the complicated root and root canal anatomies and the situations in this particular slide. Anyone wants to add any other point so that it will help us moving forward?
Doctor, you can go ahead, doctor.
So once you've
everything is
but this complicated root canals are classified, I would, there's no textbook which is given this. This is my clinical experience. That's the way I've listed it out. The most common thing why patient comes to us is because of the pain. And once the patient is landed with the pain, is an extraction therapy. And most of the patients are well aware in a tier 2 city and as well as in tier 3 cities that they want to save their tooth now. But the challenge here is to handle two things. One is the physical pain and the psychological or the Google pain. I call it Google pain. The reason is patients read too much about their root canal therapy or dentistry and come to us. So you should be able to psychologically manage it. So that is the individual skill and the need of the profession today. Because they are over-informed or uninformed, I would say that they are misinformed. So what exactly is a root canal? If patient asks me, I don't talk too much, I don't explain them too much. If explaining them too much also creates a lot of confusion. Have you seen any cardiologist talking to you? Though even if he's your friend, he will not explain what he's doing. He will just say, I'm putting a stent. He will try to maintain professionalism. You and me as a dentist have walked too much towards the patient thinking that if I educate the patient too much, he will be nice to me. No, that is completely wrong. Educate him professionally and not friendly. Don't become too friendly to your patients. Encourage them to know that you are doing and your work is something complicated and you are helping the patient to achieve good results. So I only call what is root canal treatment. I am telling the patient that I am creating a biological environment for healing, and for when it comes to the part of shaping, we are creating the canal in such a way so that you can do the sealing job. If the canal is narrower, how can you seal it? You cannot seal it. You do not have something flowable wherein you can just push it inside and it will get sealed automatically. So in simple terms, if somebody asks me what is root canal, I say I'm creating a biological environment for a natural healing. For that, I need to create a natural process of shaping the tooth and I'm making it comfortable for the sealing job. So knowledge can be gained by going and listening to lectures like us, but skill has to be acquired. Doesn't mean that you look at my presentation, you see my presentation and go and directly try tomorrow. Please don't do all those things. Skill has to be practiced, skill has to be acquired, and it's a day-to-day process. So what microscope has taught me is to see things. Why did I buy microscope when nobody in dentistry, even for the day when I bought a microscope, people never sold a microscope to a dentist. They were saying, you as a dentist, why do you need this? Then I told them, please give me, because I do not see what I'm doing. But the day when I started seeing what I'm doing, that's why I'm sitting in front of all of you and I'm privileged to share the knowledge what I've acquired. Okay, so I would request each one of you to acquire the skills, but knowledge can be gained in a vast way. listening to many lectures, looking at videos. So what are the skills that you need to acquire? Is that one is that you need to first and foremost have these skills to diagnose. So you need to know your clinical knowledge, why this pain is coming from, where this pain is coming from, and whether this tooth, identify the right tooth. Hope you'll all agree with me. The next common problem as a endodontist or a person who's doing a lot of endo work is failure to achieve anesthesia. Once you cannot achieve anesthesia, you are always, the patient is not comfortable, you are not comfortable. You don't know whether you have gone to the apex or you have completely shaped and cleaned. So achieving anesthesia is a key factor, and I will tell you some tips that how you can do a better anesthesia. Isolation becomes an important role, though you don't use rubber dam. You cannot use rubber dam, but rubber dam should be used in all the cases. Convince the patient. This is one of the important aspects, but at least ensure your canal where you are preparing after you open up the access cavity, ensure saliva not getting inside. So the other anatomical challenges, what skills you'll have to acquire is to identify the canal orifice. To identify the canal orifice, you should know the anatomy. If you look at your Black's cavity preparation, first and foremost, they said outline form. What is outline form? So that you include all the fissures, pit and fissures, right? So that there is no damage happening. If you are not included all the pit and fissure and removed all the caries, if you are not keeping the outline form in a healthy tooth structure, then the purpose of doing a filling is defeated. Similarly, the outline form has to be applied to your endodontic access cavity. What is this outline form? For that, you should understand the internal anatomy of the tooth. If you understand the internal anatomy of the tooth, automatically your outline form comes in place. So the outline form in endodontic access cavity is determined not from the external tooth surface, but it is determined from the internal tooth surface. For example, if you see incisors, the outline form for an incisor should be inverted triangle. The base of the triangle should be at the at the incisal edge, and the cone, that the apex of the triangle should be at the cingulum. So why that shape? Because there are 3 pulpons, and if you do not achieve this shape and make a small hole thinking that you're too conservative, then you have left a lot of coronal pulp tissue in the pulp chamber. Similarly, premolar has an oval shape. Then you come to the upper molars, you have a rhomboidal shape. You first create the shape so that the whole internal pulp chamber is exposed. Once it is exposed, automatically in the corners of this geometrical shapes, you will find the canals. Next is to achieve patency. Once you open up the access cavity, ensure that you have patency. If you do not have patency, then there's no point blaming a rotary file that this file didn't go and other things. First, confirm whether the files which you open up and insert into the canal goes to the estimated working length. What is an estimated working length? An average molar today has 20 to 21 millimeters, provided the occlusal tooth surface is existent. If it is not, then you will always have a problem that the file is not gone, so you cannot expect your rotary file to cut through that calcification and go automatically. That's the reason you need AND files. And the other thing is working length determination. The inadequate shaping of the root canal. Some of the rotary files or your AND files cannot touch the entire anatomy of the tooth structure. If you have a young permanent molar and the patient comes inside your clinic and you expect the rotary file to do the job, it will not do, because your rotary files are made for complicated root canals where the root canal anatomy is narrowed down. And these rotary files or any AND files what you have cannot touch the entire dentinal wall. So you just need a simple H file to do a circumferential filing. So please do not think that I got these 3 files or 4 files with me and I'm going to put it anywhere and everywhere. This is what I wanted to bring upon, saying that judiciously use these instruments, understand the anatomy, and then move forward. So coming to this, we will also touch upon the need of antibiotics, improper cord buildup, and adequate tooth structure. One of the foremost indications and contraindications for root canal therapy is the amount of available tooth structure. If the tooth structure is not good enough, what is the point? If their caries is extending below the gingival area, you can might as well, your restoration failure will be there. You might as well can educate the patient to go on for an implant. The reason is there is a restorative failure and not a root canal failure in that particular tooth. So very important, important step to move forward is to failure to diagnose. You need to know where the history and the type of pain the patient is experiencing for the ultimate outcome. If you have not diagnosed the right tooth to be treated, you will always have a problem where the patient might come back and say there is some other issue. Clinical evaluation, what do I mean by that is if a patient does not have a 3-finger mouth opening, 3-finger width of mouth opening, please do not attempt endodontics in the molar area. It is quite challenging to introduce the instruments. There is no convenience form. If you do not have a convenience form in the cavity, you cannot condense amalgam. Similarly, if you do not have convenience form in the mouth opening of the patient, you cannot do good endodontics. Radiographic assessment is important. If you look at the orthodontist, they do a cephalometric analysis to understand where I stand and where I will, end when I do my treatment. So your preoperative radiographic diagnosis will allow you to check whether the canal is patent, whether the canal is seen, or whether there is any calcification, whether there is any periapical pathology, how much time the teeth will take to heal, what all challenges you'll have, what all postoperative complications you'll have, and finally the operator's ability. If you are not trained to treat, please do not touch it, please do not damage it and then refer it to somebody and then make the whole root canal treatment complicated to the patient, and patient themselves will say root canal treatment, we have to go many times and the doctor will ask you to come for many visits. So you don't need all these things. You as an ambassador for dentistry, please do not spoil the treatments just because you have not gained some knowledge. So invest time in gaining knowledge and also applying to gain the skills. So a simple tip for all of you is that anesthesia is one of the greatest challenge for all of us. In medical specialty, there is a separate anesthetist who will actually take care of the headache of anesthetizing a body. Then a surgeon comes and operate. But you and me in dentistry, we do not have a separate anesthetologist. So you and I also have the responsibility of understanding the anesthesia techniques used in endodontics. The technique what you use for extraction of the tooth is not same for the root canal therapy. You must be finding this in your day-to-day practice. Dr. Sujata, I think you will agree with me that most of us have challenges in doing this anesthetic. Once you anesthetize the tooth is still paining. The patient is not allowing you to enter the pulp chamber, right?
Yes, sir. Yes, sir. You're true.
The practice is that you will ask the patient to come again. You will put one devitalizer, thinking that all the pulp will die automatically and the next time something will happen. But using devitalizers, using other adjuncts will not help you. For that, you need to understand the anatomy of the tooth. Anatomy and you should practice atraumatic techniques. You cannot just try to be crude and using intrapulpal. Intrapulpal is the most crudest technique of all. But what are the alternatives and what are the best practices? So when you look at it, instead of you just piling up xylocaine in your operatory, please buy something called as bupiocane. But this bupiocane is not available in bottles like your xylocaine. But this was one company, AstraZeneca, which used to supply, but then now they don't. You get vials of bupiocane. So when you see the patient is having an odd tooth with normal anesthesia is jumping even after 2 or 3 blocks, just inject this bupiocane 0.5 without adrenaline. You will see wonders happening. But there's a whole thing why this bupiocane works in such situations and why not xylocaine. But at least have this in your operatory so that ensure that the patient, when you actually open up on the first sitting, if you're doing a 2-visit endodontics, the first visit itself should completely eliminate almost possible pulp tissue from the root canal. So I would like to introduce Mani, and I've had a close association Mani from almost our undergraduate days. But what I like about Mani is that the quality, and it helps you stay safe. If I pick up my tools, if I buy my car, I look for a good brake, I look for a sturdy body, I look for an ABS. So that's Mani for me when I'm doing my endodontics. It gives me a fully power-packed protection system, right? I can blindly believe and work on these files because they have time tested and they have celebrated their 50 years in dentistry. They have been really well, and I've been privileged to even go and look at their manufacturing facility. I'm a person who doesn't just believe in stories. I want to touch and feel my things. So any new product which comes to me, I assess under my own microscope, and I don't just believe the text which is offered by the companies. So you see, I have for the endodontic range from the burrs to the access opening burrs to the high-end microscopic instruments which are there from the Mani. So this is Mani for you, and I'm going to focus more today on your rotary files because that is what is needed and everybody is fascinated on biomechanical preparation with nickel titanium rotary files. Before even moving to all these things, as all of us know that we cannot see what we are doing. And endodontics is to be one such specialty where everybody was proud of saying the one such skill which you need to equip yourself is the tactile sensation. If I don't have the tactile sensation, I'm not an endodontist. That is what is taught to us when we did our post-graduation. It is just that I know I'm at the apex. I know I can feel the canal. I know I can cut the file is cutting this. But what happened when the rotary files started coming into picture is you started losing that tactile sensation because everything was attributed to the machinery. But when that happened, the accidents also increased, right? So you started breaking more files because you didn't know what was happening inside. You cannot have a control using a aerotor as compared to your micromotor. Do you all agree with me? So when that happens, you need a tool to see what you're doing. Microscope, and please do not attempt to do any high-end procedures or even dentistry without magnification. I don't say that you need a microscope for all your cases, but at least you should have a 2.5x loop. And I've been a strong propagator of use of magnification. The reason is, if I see things, I know whether I'm cutting it or not, or I will see whether my tool, whatever I intend to cut, is cut or not. So for you to be a good dentist practicing quality dentistry, you need to see things properly. And why you cannot see things properly is your human eye is not equipped to do dentistry. It is equipped to do for you to survive. Why is an ophthalmologist using microscope? Why is a neurosurgeon using microscope? That's because their eye is not made to perform such high-end procedures. So if you and I don't value our profession, all of us know that we always nick the adjacent tooth when I'm doing my crown cutting. That's because you're not seeing it. And then your failure starts. You would have done a good crown, but adjacent tooth is nicked and the micro leakage, or what you call food accumulation, starts. And then there starts the problem for failure of endodontics. You would have done an ultimate endo, but since because of your adjacent tooth damage, a periodontal problem sets in, then a retrograde pulpitis happens or retrograde infection happens. So my humble request is to own one magnification tool of any form. So coming to the BMP in per se, till now, do you have any questions or any points which you wanted to touch upon, or can I proceed?
Sir, sorry to interrupt, but can you, which is the best loop to buy, and which is, for a general practitioner, can you suggest something for us in the concept of loops, please?
See, I use JIZAI. So why I buy JIZAI is that my eyes are important, sir. If I buy a low quality loop or a cheaper loop, I am not assured my eyes will be fine. So you think what is important for you now? I have been using this microscope for 15 years. My eye power has not changed. I am not a JIZAI company person. I am a dentist who uses quality products, the way I like to use money. So similarly, if you pick up a loop, why do you think a loop is expensive? Because it comes with certain amount of quality and grading. Believe me, my son uses the same loop. He asked me to bring the loops for him to remove his small car screws from his small cars. So this can be passed on to your next generation. An investment of a good loop will not cost you anything less than 80 to 90,000 rupees. If you buy cheaper loops, you will have to go to visit your ophthalmologist and pay a huge price. This is how I can define it to you, but you can take that decision based on why and ask these questions if and buts if somebody is coming and selling a loop to you. A 2.5 why I suggest is because you will see a broader vision while working in endodontics or dentistry. We dentists are not provided with assistants who will pass the instruments directly to us. So we need some amount of good vision. If I go for higher magnification, I'll only see one tooth. Then what happens around me, I don't know. I can damage the patient, poke the tongue, everything will happen. So to start with, for general dentist, a 2.5x from a good company, and TTL. If you can see in this loop, it is made and engraved into the glass and fixed. So this is a fixed and personalized. I cannot share this loop with anybody else except me. So any other questions apart from this?
So you can continue, sir.
So one of the greatest skill that we should have now is to ability to have something called as glide path. Glide path is nothing but checking whether the canal is patent till the apex from the orifice. Okay, if this patency is not there, I cannot do any endodontic procedure. I know my endodontics is going to definitely fail. So for that, to make the initial assessment, and files are the key tools. All of us know that we are introduced to K files. We all know K files have been there from 1904, from many companies have been manufacturing. But I'm going to introduce you that these K files have certain disadvantages. Above the size of 15, these K files become very stiff. Okay, they can cause stress and open up this curvature. The curvature which was like this will be opened up. Once it gets opened up, you are unwantedly creating transportation, right? You're zipping off the canal from the original dimensions of it. So you're removing lot of dentin here and the cementums are exposed. Microfracture creates. Your guttapercha might look nicely obturated. Over a period of time, you'll see something failed. There is a periapical lesion here. That's because you have opened up the curvature, removed all the dentin. If we all know, we remove all the unsupported enamel. Why we remove the unsupported enamel in a restoration? If it's not, backed up below the dentin, that enamel will break. Similarly, if you remove all the dentin within the canals here, there is only cementum left, which can create micro cracks. So you should not use a K file in exploring and doing glide path. Now you should be using something called as glide files, which are very recently launched, and a D finder from Money. They also come in sizes similar to their K files, but they are able to handle the curvature and maintain the patency as well as possible compared to K files. So this is the change. The first change you should make in your endodontic armamentarium kit is to buy a glide files or a D finder and not stock too many K files. That's the first change. The lubrication is the key. You cannot introduce any file into the canal without lubrication. What could be the lubrication? You have your EDTA gel, which can be coated and smeared into your file and then only introduced to do your glide path. And the technique is very important. I will share you the technique. And finally, which is not available with a lot of male dentists, is patients, including me. So endodontics, if you look at a lot of the endodontists in the country, all the senior endodontists were all women. So what we should learn from them is being patient if you have to do endodontics. Hope you'll all agree with me that male dentists do not have patience and we need to develop it. Female dentists already have it. So that's their shastram. I can say that that's their shastram to maintain the glide path and patency. Now coming to the initial canal exploration, as soon as I open up my access cavity, I should just check whether the canal anatomy is clean enough. So why I use a glide finder or a D finder is that these files are more stiffer. I mean stiffer in sense ability to take up load, unlike your K files. You must have seen your 8 size and 10 size K files. You put them into the canal. Once you rotate 2 or 3 times, it will unwind immediately, right? A very new file. You put it into the canal, it will unwind because there is a curvature which is very steep. And that's why it unwinds. But that will not happen to your D finders as well as your glide path files. They are much stiffer in that sense and tougher. The toughness is about 1.5 times more than that of your K files. Just imagine you're going to buy number of K files. Instead, you buy a glide finder and a D finder, which is much more tougher, and you don't have to keep throwing these files. Once that shiny surface comes in your K file, you'll always scared to use it next time. But we are very, very, conservative in thinking, it's a new file, should I throw it? But that's when that happens. Your intuition tells, and a K file has the ability to show you that it's going to break. But your nickel titanium will not show you the signs of warpage, and that's when you land up in problems. So my simple, humble request to all of you who are doing endodontics is to use D finders or glide finder files, which should be your initial canal exploration files and not your K files. Okay, the flutes of a D finder is D shape and they are safe and efficient. If you look at my technique, I am just exploring the canals using these D finders, and they are also available in size 12. You have a challenge when you're using a 10 size file and jumping to 15, the 8 to 10 easily goes through. But when it goes to 15, you find it, the 15 is finding difficult to go. That's when you use force, and that's when you create a ledge. So with this D finders and glide finder files, you have a size 12, which will help you to have a nice transition between 10 to 12 to 15 easily. So this is another added advantage. And finally, here's a Money Glide Finders, which is very newly launched. Amazing files. They have adapted a technology where if you look at the cross section is square. But in your K file, the cross section is square throughout. But here, the cross section is smaller in diameter. It goes to make it stronger as it goes towards the shank, so that there is stiffness and enough flexibility and strength as well. So please recommend you guys, the dentist, to use these files. Check how efficient they are, because what is ultimately required, the first question asked by me was, what is that you're looking? If you're looking for successful in your endodontic procedures, the first impression is the best impression. So you need to use these files, which actually create a a good glide path for the rotary files. I always tell this: the rotary files are like blind men; they cannot go on their own. They need to be showed a path. So the path is shown by these files. That's why they are called as glide path files and glide finders, or whatever you want to name them. They are amazing files. I think the cost wise also, they're quite affordable. Unlike most of the companies, if you look up most of the MNC companies which are not focusing on the professionals, only focusing on their business, they will introduce to you something called as pro finders, path finders, which are still rotary files. They're going to be increasing your armamentary cost. But here is a file for you which will help you to save your cost, yet stay safe and get a great results. So if you look at the cross section of these glide path files or glide finders, they are amazing. They have good channels where your debris can be pushed. And this is very, very important for us. When it cuts, it also should have an ability to push and not push the debris beyond. When you have a post-operative pain, to whom you have to attribute, it is to the instruments. Because if instruments do not have a proper flute angle, all the debris will actually be pushed outside. Once it's pushed outside, whatever debris is cut, then only the post-operative pain starts. The ability of these glide finder files are that their debris is pushed more coronally and not apically. So if you just look at this video, this is a video showing how to do your glide path. You take a small file, you can see how nicely you should nimble. You should not use force. You're able to see so well inside my what you call the canal. It's only because of the ability of what I'm using is the microscope, and my force is very, very gentle. I'm not pushing it or struggling. If you see, I'm just trying to explore it. Are you seeing the flutes? They are not unwinding even if I'm using. And yes. I'm nimbling it. I'm not using any 360-degree rotation. I'm just gently nimbling the files into the canal, checking for patency. In and out, my canals have to be wet. I spend more time on exploration of the canal and checking for patency, and a very less time for biomechanical preparation. You see the flutes, and this is the definder, which will help you to push all the debris. There are channels for you can see the channels here. These channels can bring out, and the file is much tougher and stiffer as well. So
class teacher
there's some disturbance.
Kindly
So any questions on the glide path and the difficulty you people face in doing this glide path?
So please proceed, sir.
Okay. So the next thing is that we need to understand about the customization of root canal. Why is root canal needs to be customized is because we do not know the anatomy ourselves. So one of the simplest way for you to picturize your tooth is that you have large canals, you have medium canals and small canals. The canals which are coated in blue are all small and difficult canals for us to prepare. So we need to be more careful in handling them, and we need to have more skills and the knowledge of them. The medium canals are much easier to prepare, and large canals, of course, don't require even rotary file. A simple hand file can be done. So a clinical case assessment and a radiographic. As soon as your case comes in, you introduce an 8 type file into the canal, and it is going with difficulty or with however you experience the difficulty, tells you that the canal is more difficult to work on. And if the canal is 8 type is loose, then you go to 10. And if your 10 is going, it's okay, it's a moderate case. But a 15 size file introduced into the canal as soon as you open up an access cavity is easy for a rotary file. So if your size of the canal is 8, you'll have to graduate to the size of 15, then only introduce rotary files. And doing, bringing this canal from size 8 to 15 is something called as glide path, and you use those glide path files which I just introduced to you, and that is entirely the skill which you need to possess and
Sir, your
acquire over
voice
a period of time.
breaking, sir.
Hello? Can you hear me now?
Yeah, proceed. It's clear now.
Can you hear me now?
Yes, sir.
Yes, sir.
Yes, sir, you're audible. Please.
Close.
So this is what I meant.
Please.
This is to assess the difficulty what your rotary file is going to get. So you need to bring the size 8 size canal to the 15 size before you introduce rotaries. So the other important factor, as soon as you introduce a rotary file into the canal, an AND file into the canal, especially the K file, and try to bring it out, you'll see they deflute. They deflute in such canals. They are called as radius of curvature is very small, wherein some canals it will just pass through. So this is not visualized in an radiograph. We don't know how severity is the curvature. Let's say that there is a curvature, but when you go to a curvature and an hairpin bend, it is like hairpin bend for us. This can be only assessed by you clinically. So in such cases, where is that glide path files are going to help us? They're going to improve the severity of the curvature and try to make it like this. If I put a rotary file in this curvature, it's going to definitely break. So I'm going to improve this curvature by making it more smoother. That is the reason for glide path and customization. And you don't get to see three-dimensional picture of the canals. So the other important factor for you to clinically identify is where the curvature is starting. Curvature starting in the apex is more easier to treat. Curvature starting in the middle, because beyond the curvature, the length of the canal is more and it takes more time to prepare. So you will also experience why it's difficult is because the length here is very small. Then you need to open up, clear it up and other things. So how do you do this? Select a file that is smaller than the canal and insert it, rotation until it goes and stops. There is a resistance. When it resists, don't try to further push it. So that tells you there is a curvature starting. And once it stops there, you now try to move it clockwise 1 or 2 times. The amount of resistance it offers tells you how severe is the curvature. If with one push it goes, that means the curvature is smooth enough, the rotary files will not get stressed. But if you take 2 or 3 turns, that tells you need to still work upon with your glide path files and then make this canal better to introduce your rotary files. So you cannot treat all the variations. All variations are like this. This is the C-shaped canal. So you should be ensured and understand that all the files cannot touch all the surfaces of the root. You need other instruments to further do it for getting the success. So microscope gives me an edge to understand how the surface of the canals look. So with this, we are going to talk about the rotary files. Moving towards always all of us have a confusion, and we are more motivated or influenced by the neighbors. We do not just by an ad or somebody's telling I use this, it worked for me, it works for you, but it is not like that. A simple few tips which I'll give you. What are the basic criteria? When I say it is an antibiotic, I should say which all bacteria it works on, whether it is having a broad coverage, or if I want a target area of antibiotics, I should know. That knowledge we have. Similarly, I request you to take these take-home messages on any new rotary files coming into the market. The file should have this many qualities. If it doesn't have, like if I say from amalgam, how is composite difference, I need to have some 3 or 4 points. Similarly, today we are going to talk about a file called as JIZAI, which the money is introduced. And very important is that how do you select your files? One and foremost important thing is to understand the canal anatomy. As I mentioned to you, the curvature, how much is the curvature, and whether which file can take this curvature has to be understood. Next thing I mentioned to you, 3-finger mouth opening. If it's not there, using rotary files is a challenge. So the JIZAI files are safe and efficient. If you look at any tagline, if I have to give for this particular file, for me, safety is important because I'm using a nickel titanium rotary files, which do not tell me like stainless steel files that it's going to break. It will not give me a warning. And efficiency is required. What do I mean by efficiency is that it should make my job easier, number one. The next thing is it should not spoil the canal anatomy. So that's JIZAI for you. You'll find it safe and efficient. Now, coming to the cross sections and other things, these are all good for manufacturers. These are all good for others. But you should know what technology of the file are you using. So if you know, nickel titanium had something called as austenite. They were given to us initially when they were manufactured way back in 99s and all in an austenite form. Then in between in 2008 and 9, they started making something called as martensite form, which is a daughter phase, which is more flexible. But recently there is something called as a rhomboidal phase or in between phase between martensite or an austenite, which is called as a controlled memory technique. So what exactly happened with an alloy or a nickel titanium is they went on trying which is good for the dental profession. So now what is the greatness of this JIZAI file is that something called as a radial land. If you look at the flexibility of nickel titanium, the austenite file itself was flexible. What is flexibility in nickel titanium? When you actually put a stress, it will flex, and when there is no stress, it will open like a rubber band. Your rubber band can be pulled 100 times, but the 100th time, it will not have the flexibility of the first time. So it loses its flexibility and then it will break. So, but it will not give you warning. Similarly, they went on changing the flexibility. Here it was already flexible and had shape memory. Here the problem happened was that it became too flexible. If it's too flexible, it will go to the inside the canal, but it will not cut. So then there came a phase saying that it is too flexible. Let's have control memory. We'll put it in whatever shape, it will stay there, but it will not go back. It will only go back when you heat it. So that is a better way to do it. But still it was flexible. But this radial land, if you have something too flexible, putting a radial land actually helps in cutting. We need a file which cuts, not only just goes inside. Why don't you think that why nickel titanium should have been given an AND file, right? Nickel titanium should have come in AND file. Why it came in rotary? When stainless steel files were there, the first thing which came was nickel titanium AND files. The nickel titanium AND files used to go inside the canal and buckle down like a noodle when you twist them. When you turn them to cut like the K files, the way you turn them circumferential motion, it is to just buckle down like a noodle. It will not cut. So all your rotary files till today are super flexible, but they're not efficient. You might think that the control memory files or the newer files, what is available in the market, your rotary file will go, but your gutta percha will not go. That's the reason, because they don't cut. So the Money JIZAI is made an innovation where they have put one radial land for doing that efficient cutting. And that's an important feature of this file. Now coming to the cross section, you see the cross section, it is so well managed. And the tip is also slightly cutting. Till today, you never had a file which had a cutting tip. All the nickel titanium rotary tip has a non-cutting tip. But this Money JIZAI, with the help of technology, with the help of radial land, with the help of flutes. If you look at the flutes, they are always having a jump, and I'll tell you about the flute angle as well. So this is how the cross section looks. The rake angle has a negative rake angle to prevent the screwing in effect. This rake angle is what you need to know. They cut the denting by scraping motion, not in cutting motion. Unlike most of these files, the rake angle is negative. So when it comes to the fracture resistance, why I say it is safe is, as an Indian dental scenario, we want a file to be used for more number of cases. But that's the normal thing. But unlike other countries where the files are used only once or twice or maximum 3 times. So when you look at the comparison of the study, where says that the cyclic fatigue test, that means around a curvature, how many times the file was able to rotate before it could fracture compared to the other brands, this had the highest resistance, which is in a newly published journal. For all of us, I also have done the testing. Maybe I will just publish the video shortly. I have a jig which will help to test us how many times it can rotate. This is the study done in Japan. But I also have done, which I'm making a study and I'll publish. The file is ability to rotate for more number of seconds at the same speed without fracture. So these are some of the things which are very important. But what is important for me clinically? How do I use this technology to the best of my knowledge? Whatever technology comes, there is something called as a dentinal triangle. If you know, in maxillary or anterior teeth, we were taught to use gauge grid and burr to remove the the palatal groove, or what you call the triangle there, to remove the interference so that you get a straight line axis. Similarly, there is in the tooth, even if you have done a good access cavity, this is a very micro feature which is only seen in the microscope, or this small elevation of a dentin has to be removed. Then you can introduce the rotary file so that don't get stressed here. So I use piezo reamer size 1, which is 70 tip size, which is a non-cutting tip. I am not using this as an orifice opener, but I'm using this to remove this dentinal triangle. What I do, I introduce that file into the canal orifice to just get guidance saying that this is the canal, and just move the handpiece towards the other side. Let's say if this is a distal root, I push it in a mesio direction and push it in the distal direction. For a mesial canal, I introduce from the distal direction and move the burr onto just the handpiece into the mesial direction. By doing that, I selectively remove this piece of dentin. So here is the single length technique. That is what I wanted to tell you. Please do not compare this technology with the already using existing technological files what you have. That you have coronal file, then you have middle file, then you have down file. Like what you say, that crown down technique. So this technology, you can use it in any way you want. But the way these files are made, the ability of control memory and the cross-sectional design is made this file that you can actually use them in a single length technique. What do I mean by single length technique? The way you introduce your hand files directly from 15 size from up to down, it goes, right? Does it go or not? Or it's saying, no, only 8 will go, 10 will go. No, it goes. Similarly, here the technique is very simple. You have a 2504, 2506 and 3504. I will tell you in which all cases and how to use them. The recommended first and foremost glide path is a must. Any rotary files, glide path will remain the must. The next thing is that it has to be run under 500 RPM and a 3 torque set for all files. All instruments require same torque, and use the file in slow in and out motion. You just allow them to cut. If it's not cutting, pull it out, just clean it and reintroduce. So you have a stopper which you have adjusted and take them accordingly. So this is the recommended technique by the company. So this is what you have as what you call straight and severely curved canals. So first and foremost is that you use your 2504, then you use your 2506. If you feel your canals for, say, distal canal, I use my 3504 directly into my distal canal. I don't go through the sequence because this will not even touch the palatal canal or not even touch the distal canal. So I can directly use a 6% 25 and then finally finish my apex with my 3504. A severely curved canal, I only use 2 files. That means to say I use a 2504 for full length, then I use 2506, required or not, based on the severity of curvature. So here I have classified it further to make it simpler for you. There is also an orifice opener, but which is not packed into your regular pack. You'll have to buy this particular orifice opener separately. So this is a 25 for 14%. You use this in the coronal area if you feel so, but I would recommend that you can directly go with these 3 files. So for your small blue color canals, that means small canals, I use after my glide path, I can use glide files. Maybe you might find it that 15 I use, and how can I use 2504 directly? You can use a glide file 20 size if at all, if you feel that. But in my clinical experience, the ability of this file or capability of that file is to gradually enlarge the canal throughout when it is entering the canal. So 2504 works great. You don't have to worry about the logic behind how a 15 and a 24 tip size can be shaped into the canal. So I use this in small canals most of the time. And if I find this small canal 2504 reaches, I don't want to force my 2506 if the canal age of the patient is a mattering fact for me. If any patient who is the above age of 40, I always like to finish my canal with 2504 itself. I don't want to push other 2 files unnecessarily for the sake of opening up the canal because they're packed in the pack. So in younger patients, I use 2504 and I use a 2506 for the similar smaller canals. When it comes to my premolars, I directly use 2506. And I find it 2506 is sufficient enough for me to do that. But age is another factor. So age is another factor which is very important for us. And when I'm using on a premolar, I would directly use 2504, which are narrower, especially when the premolars are older enough. and then use the same technique. 2504 and 2506 is similar to that. But when it comes to palatal canals, I directly use 2506 as my first file till the working length, and I use 3504 to finish my apical area. Because most of your apical area is very important. 25 size could not be your apical size, and 3504 is a finishing file for my bigger and larger canals. Any doubts at this point?
Participants, do you have any doubts? You can just
because
ask
this is a
Dr.
crucial point that you might have a confusion and a lot of questions or currently using your current files over this.
Sir, please the sequence once again.
So sequence is simple like this. For a smooth regular shaped canals, you use your 2504. Sorry, you use your 2504. And then if I find that 2504 is gone to my working length, I look at the age of the patient. As the age of the patient happens, the dentin becomes very narrower and narrower. I don't want to force a next size file just because the file is given in the pack. I'm happy that 2504 is done and I leave it with that. But if the patient is younger, let's say a 25-year-old and doing, your 2504 would have not touched all the surfaces of the canal. So in that cases, I use a 2506. Okay. When it comes to the distal canal or the palatal canal, I use 2506 as my first file. I don't use this because this is too small for a palatal canal. I see again the age of the patient. Okay, the age of the patient is older. I just finish off with 2506. But in case if I don't see 2506 is a younger patient, and then I use in my palatal canal the next file which is given in the box, which is 3504 to finish as my final. So I mix match these three files based on the canal anatomy. I mean to say, I say the canal anatomy is a small, medium, and large, and I've colored them right. And there is also an orifice opener. Before doing that, before doing anything, I like recommend you to use the piezo reamer size 1 to remove that dentinal triangle. Then the effort and the load on these rotary files becomes much easier. Is that okay?
Yes, sir.
Yes, sir.
So no other questions?
Sir, even
No
though
other-
if we use definder, glide path also we need to use, right?
No, you can either use a definder or a glide path file. The glide path file is a new inclusion into the market. So that's why I'm talking, but both are comparable. But glide path is a little better file compared to a definder, which was already there. But don't ever use a K file for doing your glide path.
It's a very simple
But
question, sir.
recapitulation.
It's a very
But for
simple question.
recapitulation.
Yeah, ask ma'am. You ask ma'am. Ask ma'am.
Yeah, thank you, sir.
Ma'am?
Hello.
Yeah.
Hello. Yes, ma'am.
Yes, ma'am, you can proceed. Yeah, please ask, ma'am.
Okay.
If you
Sorry,
have
I
any
forgot.
doubts, you can just clarify.
Okay. Sorry, I forgot. Let him ask.
Sir, one more question, sir. 50 years old male is coming for a canine root canal treatment, upper canine. Tell me the sequence of the file. Tell me the sequence of the.
I will use 2506 for a canine first, but not to the full length. Hello. Are you with me, doctor?
Proceed.
I will use 2506 as my first file for canine. Not till the working length, but I will then use 2504 till working length. This is my sequence for canine. Because canine has a very different calcification pattern, and I don't want to push a 2506 throughout the length. As I mentioned to you, I am a mix matching of all the techniques. Canine is a very long tooth. The risk of preparation is entirely different. You'll have to mix match a crown down versus a single length, and cannot allow a single length to go till that length. See, an average tooth size is about 21 millimeters, out of which 10 millimeters is your crown. Remaining portion is your 10 millimeters is another canal portion. But when it comes to canine, it is the other way. The ratio 10 millimeters is the crown size, but almost 20 to 20 millimeter will be your length of the root. In such scenarios, whatever I told you might not help. So what I will do is in a canine like this, I will use a 2506 till the middle 1/3. Okay. So that will actually create a good crown down for me. Then I will take my 2504 till the working length. Then I'll use a 2504 as my master cone, and I'll use some lateral condensation and use some 2% cones, or I use a thermoplast size to completely do a down pack and a backfill using thermoplastic gadapacha technique. Is that fine, doctor?
Yes, sir. Thank you. Thank you.
So these are some of the pictures of the files. You can see the files. These are clinical pictures not provided by the company in my clinic, where I have taken the flutes. If you can see, the flutes are seen. There is a good amount of space here. And the next few pictures will also show you that this is a picture of a orifice opener, that it's cutting and pushing the debris here. And if you can see the debris collected in the files, can you see this? So the debris, whatever is cut at the apical area, is pushed more coronally. The other advantage is the controlled memory file. You can pre-bend this file and introduce into the canal. Unlike with other rotary files, you cannot pre-bend them and introduce. So what will happen is you don't need too much of an unwanted removal of the dentine, but the removal of the dentine at the coronal orifice, which is called as the dentinal triangle, can be removed, and your files can be, even a patient has a limited mouth opening, and over a period of, as I given you a norm saying that 3-finger mouth opening is required, even if as if you are experienced, you can actually bend these files and introduce them into the canal as well. So these are some of the advantages of these files over the other files. So if you can see how I'm actually literally bending the file and pushing it into the canal, but it still goes and does its preparation. You can see the blade and flute, and this is the radial land what you see. So this is where the file is becoming safer, and the flutes, which is the rake angle, is able to cut the denting. So these are personal assessments. So once these canals are prepared, I keep the canals wet with hypochlorite, so that hypochlorite is like a good dissolution agent. It removes and clears all the smear layer generated. So if you look at, this is a picture of a block which was before preparation, and if you can see, this is the preparation after the block, where orifice opener in this block, all the files were used. An orifice opener was used till here. Then we used a 6%, you use a 2504 to the length first. Then you used a 2506 to the length. Then I used 3504 to the length. Even after doing all these things, the canal anatomy is not damaged too much. It is still maintaining the canal curvature. So these are some of the pictures which are used treating. These are all microscope pictures where you can see that the canal is well shaped. And these are some of the supporting articles to talk about the ability of the files not maintaining, means not spoiling the canal anatomy. They resulted, other files resulted in a lot of canal straightening, where the JIZAI had the lowest straightening of the canals. This is on the cyclic fatigue. That means to say how many turns it took. It was 7.15% higher than the other files which were used in this particular study. So they were all of a different phase. In fact, austenite phase, one of the oldest phase which was used, which is this. And there was also an R phase file, which is an iFlex file used in this study compared to that of JIZAI. The advantage why the file JIZAI is more efficient and it took longer time to fracture is because of the radial land incorporated with it, which makes the file more safer. So these are articles. You can just look at small this about how the canal was prepared. Sorry, this file cannot play. So I will take questions here. I have just roughly covered the whole session for today. Sorry for all that initial glitches which happened regarding the PowerPoint presentation. Now we can, this question is open, this forum is open to take any of the endodontic questions you have. We can spend more time on interaction rather than listening on to the presentation.
Sir?
Sir?
Can we use, hello?
Berkman sir, please wait, sir. Berkman sir, please wait. Madam, I think you can ask a question. I think Berkman sir will ask next.
Okay. Hello.
Yes,
sir,
madam, I'm listening.
Can we use NSK reciprocation handpiece for K files and DFinder?
No, you can use, you can use, madam. There is no problem in using. It is only reciprocation. You will further get better efficiency compared to what your hand can do. You can use that NSK's reciprocating as handpiece for the DFinders as well as the glide finders.
Madam, if I think you were. sorry, ma'am. I'm sorry for interrupting. I think you were asking something about recapsulation. If I'm not wrong.
No,
Yeah, yes.
recapsulation, you don't use reciprocation. For recapsulation, you use a simple glide path or any file which is smaller than what file was used before. So
Even K file.
I don't like to use K file because K files can become stiffer. It can create a ledge. It can push a mud anywhere because of the cross section. Now we have newer files which can do that job more efficiently. See, loss of working length is one great problem we have in endodontics. I put my first file, it will go. Second file is not going. Why it is not going? It is either pushed the mud apically and got it stuck, and I cannot remove that mud which is stuck in the apical area. So to be safe on that end, what I recommend is these glide finders and definders are introduced, which are better in removing those mud what is cut. And also, if whatever rotary file is cut, you need a file to recapsulate. So you need to go and check whether your working length still exists before you introduce your next file.
Yes.
That's fine, sir.
Yes.
So a lot of beginners are attending this. Can please tell me how to manage after disturbing the dentinal map? Please tell me how to manage after disturbing the dentinal map. In case of accident, we'll disturb the dentinal map in access preparation. No, sir. Kindly tell us how to manage.
No, dentinal map is nothing to disturb dentinal map. See, I'll tell you, dentinal map
No,
is
sir. No, sir. What I'm asking you, if something goes wrong in access cavity preparation, if we are not able to do the access cavity preparation, suppose we are disturbing the dentinal map, how to manage? Understood, sir? What I'm asking.
I'm telling you one thing. What can go wrong in an access preparation? That you can create a perforation. So for that, you should understand the anatomy of the pulp chamber. The anatomy of the pulp chamber is you have a roof of the pulp chamber, which you should remove. As soon as you remove the roof, you will find the floor. The floor only will have a dentinal map. What is dentinal map? Which will tell us where are the canals. Dentinal map does not have any role in disturbing the access preparation, or only challenge you'll have, dentinal map is there in the pulp floor for us to guide us where the canal is there if you are not able to find the canal with your natural means. Okay, doctor? Did I answer your question? If you damage the floor of the pulp chamber, you will not even have any map or anything. It is just your blind procedure or help of magnification which can help you identify the canal. For identifying the canal, you don't need a dentinal map. You don't need anything else. That is all textbook language. What you require is a decent axis opening shape. Once you open that axis correctly in the shape what is required for, if you look at your basic Grossman textbook, which is told you the shape of the axis cavity, achieve that shape of the axis cavity, completely de-roof the pulp chamber. For that, you should know at what level your pulp chamber is there from your central pit in a molar. Pulp chamber roof is about 6 millimeters from the from the central pit. Once you reach that central pit, you completely de-roof. De-roofing will give the shape of the pulp chamber. Once you have done the shape, corners of that we will find the canals. The dentinal map need not necessarily be in a younger patient. The dentinal map may not be appearing because the pulp chamber is so big. The formation of dentinal map happens as the calcification process happens.
Okay, doctor. Okay.
Thank you, sir.
Thank you, sir. Thank you, sir.
Definder, glide file, and for rotary, how many times we can use the maximum if we autoclave?
See, any instruments, you should always do your economics. What is economics? If I buy a pack of file for so amount, what is the end use of my money I'm making for the treatment? Let's say I'm actually recommended, I would recommend any rotary file for 3 to 5 cases. Don't push it beyond that. Anything beyond that, it will lose its sharpness. It has something called a cyclic fatigue, which I showed you. 7.1 times is the maximum. So don't push it more. Next, I don't know whether you use that file in same curvature. The curvatures are different. So the glide finder files and as pathfinder or definders, there is nothing like there is a risk of fracture. There is any slight warpage, you can throw them. but as much as possible, nothing more than 3 to 5 cases matter. Both your hand files as well as your rotary files.
Yes, sir. Thank you.
Any more questions?
Sir. Yes, sir. Usually we use 3% sodium hypochlorite and EDTA gel for lubrication. And finally, if I want to rinse with EDTA 17% de-smear solution, finally at last, before paper point, what the last one I have to use?
You have to use, after using hypochlorite, you have to use saline first. Then only use your, what you call EDTA 17%. You cannot directly push, hypochlorite and EDTA together. There is a formation of a reaction, and that reaction can cause a lot of damage to your periapical area and a post-operative pain.
But when we coat the rotary with EDTA gel, we apply some 1 or 2 drops of sodium hypochlorite in the canal, then we do the rotary. Is it right? Is it the right thing?
Correct, Doc. That will create a champagne effect. So when it creates a champagne effect, you should always, you are using a lesser amount of percentage of your this along with the carbamyl peroxide. You're not only using just a EDTA, but when it comes to EDTA solution, you're using just EDTA solution. What is recommended when you're using EDTA as an irrigant? It should be always cleaned with the solution, like means your saline, which will ensure there is some amount of neutrality between the different solutions used. So if you look at my whirlpool effect thing, it will explain to you that my 17% EDTA, which I use there, also has something called as a surfactant in it. What is surfactant? It is like your soap. If you put soap in the washing machine, if it does not have surfactant, the dirt will not come out. So there is also a dirt, and then there also needs to be whipping. Your washing machine whips the cloth, and then all the dirt gets come out of it. Similarly, I whip it with a plastic endodontic file, or with a simple hand file. You can just keep dynamically pushing into it, and it gets cleaned. And finally, yeah.
So a general question, sir. When not to do a apicectomy and when to do a apicectomy if there is a periapical pathology found in upper anterior. Please explain.
99% don't do apicectomy. Apicectomy is an old technique. Even if you do apicectomy, for example, this case, okay, doctor, this case came to me wherein this was the situation. Some doctors attempted to do, and he's created a perforation here. There is a big periapical pathology here. Okay. Now I don't know what to do. This was come to me. Then I threw this, I opened. I tried to find the canal. With the help of microscope, I found the canal. But I was so happy after finding the canal. I removed it with one shot because this file had got tortuous affected. It separated. Okay. Accidents happen to all of us. So what I did, I went ahead, then thinking that this has a periapical lesion. I tried to access it here. If I would have approached this area through this, I wouldn't have worked on apicectomy or doing a surgery here. But since this was not possible for me to reach, patient had a severe pain, I went ahead and did a periapical surgery, and I did not do apicectomy here. This tooth is already resolved. But I use ultrasonics to do retro preparation, not apicectomy, and placed MTA here, very small piece of MTA. I left this file, pushed MTA here again into the perforation which was created by a referring dentist, and this tooth got saved. So when to do as much as possible with present techniques, this is another case. In this case, this is completely calcified due to trauma. Okay. But I was able to go and open this through the help of microscope. I identified the calcification when. In this case, I didn't do surgery because I was able to access. And within 6 months, this rarefaction started becoming lighter. That means to say, which was darker, started becoming better. So I 99% recommend you to do an orthograde procedure for central incisors. They behave well. You don't need surgically, just overdoing it by cutting it, chopping it, opening it. You're damaging the periapical area. There is good healing if you simply follow your regular endodontic procedures and wait and watch. Don't expect a swelling of a gooseberry size to heal in 1 year, 2 years. It might even take 6 years. For it to form only, it must have taken so many years. How do you expect it to go so soon? But you only observe every 6 months, you need to take a post-operative radiogram.
Thank you, sir. Thank you.
Sir,
Thank you, sir.
One question, sir. Hello.
Yeah,
sir,
go ahead, doctor. Go ahead.
Sir, can we shape middle mesial canal with the JIZAI file, sir? Because as the middle mesial canal, the volume is very less and there is high chance of strip perforation. Can we do it with the initial JIZAI 2504 file, sir?
Yeah, you can. There is no the canal anatomy of JIZAI or the middle mesial canal. So this is a case for middle mesial. Patient came to me, some disturbance, doctor. Can somebody switch off their audio? So this particular tooth came to me like this, referring by a referring dentist. Then I opened up and cleaned it, thinking that there could be a caries here, and the doctor said it has got poor prognosis, periapical lesion. I opened it up and cleaned it up. When I opened it up, for my surprise, I found a middle mesial. Okay, as you said, the middle mesial is looking smaller than the others. If you don't use magnification, you will always land up. See, when I enlarge them equally, right? 2504 will not spoil anything. I don't use 2506 in this canal. I use 2506 in these two canals, but I use a 2504 in this canal. This is my output. All shaped well. If you see, these are bigger cones and this is a smaller cone, right? So don't think anything that this file cannot do. This file is meant to do. You allow it to and work on an extracted teeth before you get confidence to do. Because you are trained to do some other technology, saying that crown down, I'll use this on top, I'll use this at the bottom, I'll take this in the last. So revisit your endodontic in a different approach, because there is a technological shift in the manufacturing process, in the cross-sectional design and the technique as well. But today what is happening to all of us is that we are buying technology in bits and pieces. It's like I gave an example. If you buy your car, first you're buying a car with a brake, then you're buying a car with a clutch, then you're buying a car with a ABS, then you're buying a car with other things. If you want to do anything to do with endodontic technology and nickel titanium rotary instruments, the most important is, as one of the madams brought in when I said glide path, she said, why can't I do reciprocation? She's amazing. The reason is she doesn't want to, you cannot reciprocate or move the files the way a reciprocating handpiece moves inside the canal. Similarly, you all have bought one endo motor, which is an old generation motor bought 15 years back, and you expect to run a new generation file in an old generation motor. The latest innovation in motor technology, you know that there is reciprocation, there is something called as adaptive technique, and there is something called as OTR now. J. Morita has launched something called as optimal torque rotation. The file doesn't continuously rotate. Your file will rotate continuously in your old motor. When it continuously keeps rotating in 360 degrees rotation, if there is a torque, means if there is a curvature, the file cannot handle that. Usually what your torque control motor does, as soon as it encounters, it will come back, auto reverse and come back. But the more time it auto reverse and clockwise reverse, there is always a stress on the file. But when there is an OTR motion, this technology, where there is innovation in the motor technology, allows the file to rotate even if there is a torque with slight amount of anti-clockwise rotation and forward rotation. So the files do their job more efficiently if the motion technology is better. There is something called as balance force technique. If you have heard about it, by James Roux, most of the endodontists or people who want interested, go and read about it. It is a rotation in such a way that was used to treat curved canals way back in 70s. In 70s, they used to extract a molar because it was curvature, can't be able to treat. And he developed a file called as flexar files, which are used like the way I told you today. There is a glide path file. He introduced something called as a flexar files, which had a better cutting efficiency in that motion. So the same motions are duplicated into the endomotors now, which is not available with your current endomotors. And then you expect that to do it in the files, but this file does it. Believe me, I have worked on it and it does it. And I request you to try it. Thank you, Doctor. Nice question, but.
Sir, my humble suggestion, sir, sodium hypochlorite, my humble suggestion, you should dilute in distilled water and you should use, sir, because I have met with lot of complications in using sodium hypochlorite in patients' mouth. Do you accept the complications in using sodium hypochlorite? Whatever the percentages, there are complications. What's your opinion, sir, about that?
Doctor, I didn't get your name, doctor.
Dr. Berkmans.
Yes, Dr. Berkmans, I agree with you. But I want to differ with you in one way, saying that I'm a surgeon. I know the scalpel cuts, right, doctor? But I know where to use it and how to use it. Similarly, in most of the podiums, when I was talking to everybody, there is a sodium hypochlorite complication. When is the complication? When you push it beyond the apex. When will you push it beyond the apex? When you actually jam the needle into the orifice.
Yeah.
Do you agree, doctor? But why do you jam the needle? Why do you jam the needle? For that, you use a magnification. So let us not blame. And in fact, as I told you, all the shapes of the canal cannot be shaped. But your hypochlorite is the hero for endodontics. Today, I use minimum about 100 ml of hypochlorite for my vital tooth. That gives me success. So don't jam your needles. Use a Max Eye Pro, wherein the needle at the tip is not pushing the liquid. It is pushing the liquids from the sides. Okay. So
yes, sir.
Hypochlorite 5% is not available. We are having 3%. Dilution of hypochlorite is a debate, because if you look at the composition of hypochlorite, you dilute it with distilled water, it doesn't get diluted actually. The dilution of an hypochlorite should be done using bicarbonate solution, which we don't have in our clinic. And use hypochlorite as freshly opened bottle, doctor. For example, it should be supplied in an amber color, 100 ml bottle. For us, what happens? They give you in a half liter jar. You open one, the efficacy once it opens is lost.
Yes, sir. Yes,
the efficacy, what was there when you opened up, that is not there at the last drop of the hypochlorite. So that itself is a lengthy lecture and a debate. But a lot of them don't use hypochlorite thinking that it is dangerous to the patient, but it is good for the success of your endodontics. Use rubber dam. Even if you are not using rubber dam, ensure that you cut your suction head tip. If you have your suction head, it has got a tip on the top, right, doctor? I would recommend you to cut it off and just have an open suction tip and put it at the mouth of the access cavity and then try to irrigate. And when you're irrigating, it should be like gardening the plant, and it should be more to and fro motion, allowing the hypochlorite to just get in, and use a small hand file to agitate that hypochlorite to go deeper. You just put the hypochlorite for about 2 minutes and just sit and watch. I don't, that video, I will just see if I can play it for you. That same video which I had on what you call on the whirlpool effect. You will see how everything comes out. So I'm trying to pull out that video for you. Any other questions meanwhile?
Sir, how about sealer? Best sealer, sir.
I use zinc oxide based sealer called as Tubely Seal. That is one of the best sealer for me. I don't use any resin based sealer, but newly there's a more expensive sealer which is promising sealer called as BioSeal, which has bioceramics, but that's too expensive as of now, but that's going to be the future sealer.
Tubely Seal from Sibron Indo.
That's right.
Yes.
Sir, regarding this, can you use ultrasonic U files for activations or
Yeah, of course, you can. Ultrasonics is amazing, but all these things will work under microscope, doctor. Please use microscope. Please see what you are doing. Just don't say that is better, this is better, but everything is good. But activation with ultrasonics is amazing. U-file is great. You should do that.
Sir, after irrigating the canal with sodium hypochlorite, we have to just enter the PUA needle into the canal. Just do the to and fro motion. Am I right?
That's right.
Sir, can you please tell about the plastic endophile?
So these plastic. Can you all see my screen by any chance?
Yes, sir.
Yes, sir.
Yes, sir.
Yeah, this is the technique which I'm using here. You can see that I'm using 17% EDTA with cetrimide. This is kind of that's a plastic file, I'm just using it in a whirlpool effect. That's the whirlpool. That's what your washing machine also does. This is not available here in India, and this company also got closed because there were no buyers, and everything is all about sales, right? So I have a couple of them with me, and they don't break. They are coming in 2004. That means lesser than the fully prepared, this one, and it nightly agitates. So you are asking any other question, doctor?
Sir, is there something called calcified canal? Because I had once attended a seminar where the endodontist told there's nothing called calcified canal. Can you just justify this?
You mean to say you want to tell me that endodontist told there is no calcified canal?
Yeah, I had a debate with them actually.
Doctor, calcification is a normal part and parcel of a human life. Calcification is a stone formation, right? If you have a kidney stone, it's a calcification. Then they'll say you have salts. Similarly, body also has something called as constant calcification. For example, you look at a pulp chamber of a younger patient and look at a same pulp chamber of an older patient of the same age, or you compare his age. There is definite calcification. That's when the pulp chamber reduces in size. You don't call that calcification. You call that as a normal deposition of a dentin called as secondary deposition. There is a primary deposition when the tooth formation happens. Secondary deposition is constant throughout the life. Okay. There is something called as reparative or reactionary deposition. Why that reparative or reactionary deposition happens, and the quality of dentin formed by reparative and reactionary dentin is very, very hard. And that's calcification. Okay, doctor? So why that happened? Did you get my question? I told you primary calcium, what you call calcium deposition, secondary calcium, and tertiary calcium. What is tertiary? Is reparative. That means it is if you have somebody using brushing and they have a cervical abrasion, you can never find a mesiobuccal canal at all, even with a microscope. If somebody is put a composite in the tooth and that tooth gets calcified, the orifices get closed. I cannot find this one. If I go to my video, I can also show you in that video wherever I opened up for you. There's some disturbance. Somebody's mic is on. So what I'm doing now, I'm using an ultrasonic tip, okay, to remove all the calcifications which are inside the pulp chamber, which cannot be removed by burr, but with just using ultrasonic, everything is popping out. This calcification is a secondary dentin deposition, which is easily removable. But if I don't remove this, my pulp chamber will not allow me to access my orifice. This is secondary dentin deposition. But when the same secondary dentin deposition becomes more harder and harder because of two reasons. One is if the patient had a existing filling, which could be a composite, or a cervical abrasion. Cervical abrasion is one of the most complications for calcification. The other calcification, what you talk, is a constant dentin deposition from the apical area, where you will find your file is not going beyond a point in the apical area, whatever you do. So calcification patterns, if you see that tooth which I told you, one doctor asked me about periapical infection, when to go and when to do surgery. I showed him a tooth. Because of a trauma, the patient's complete canal is closed. Patient is asymptomatic until and unless the tooth turned discolored and he's got a swelling and he comes with a sinus opening, right? In such cases, that is calcification. That is nothing else. Hope I've answered your question, doctor. If you see, this is the hypochlorite action everywhere. Nice frothy formation is happening for the debris, and if I allow it, I don't use water, it automatically collects all that smear layer, which is, I'm going to the higher magnification to show you the bubble formation. So hope I have convinced you, doctor, on calcification. There is calcification, yes, and it is normal to happen.
Yes, sir. Yes.
So one more question, sir.
So one more question, sir.
Go ahead, doctor. Go ahead.
So how will you diagnose an endoperioral lesion? Always there will be a confusion. Am I correct, sir? Am I correct?
You are very true, doctor. Very true, doctor.
Please.
So that is a new challenge. First of all, you should understand where is the primary problem. So whether it is a primary endo or a primary perio. Okay. The challenge of identifying that is whether the patient has got a generalized periodontitis or a localized periodontitis. If a patient has got a generalized periodontitis, the prognosis is poor. Whatever you do, the prognosis is pretty poor. So, but when a patient has got localized periodontitis, you should find out the reasons for localized periodontitis. 99% it is because of a faulty contact, right? Or if there is a retreatment case, the patient has got a good endo done, but a crown is bad. As I told you, you don't use magnification, you dig the tooth, the perio starts. What I simply do, most of the time I get a lot of retreatment referrals. First and foremost, if I open up, the endodontics will be bad, no doubt. But the problem will not be from endodontics. The problem will be from the crown, which is an oversized crown. So there is a loss in the periodontium, this one. Just remove the crown and leave it for 15 days. You can see good perio healing. Once you have just done that, you evaluate by you going and doing an endo to that tooth, will anything improve? Everything is status quo. The patient is happy, asymptomatic as soon as you remove the crown. So now I evaluate and inform my referring dentist, the problem is coming from here. This is to happen. This is happening because of most of the dentists are, especially whoever is doing, are doing this freelancing job. They go pillar to post, they do the endo and come. The general dentist does the crown. And tomorrow crown, 1 year, within 1 year, doctor will call and say, doctor, you did this endo, what happened? This is failing. If you actually go and see, it is because of the crown which is failing and not because of the endo. We are very forgiving, and I don't know, our patients are very forgiving. Even if you do a bad endo survives, but perio doesn't compromise. Perio immediately slaps us back. But you attribute it saying that endo only is bad. Because me as a general dentist will not agree my crown is bad. Even if you're a dentist who's a prosthodontist, my wife is a prosthodontist. We both of us have a lot of debate. I do a crown and she does a crown. And if anything happens, even if you do with all logic possible, again, you'll have to push through the lab. The lab guy must have jacked it up. Lab guy must have not done the contour properly. I have done my finish lines amazingly. But in that particular tooth, you have to go and read this textbook called as Marzuk. I don't know how many of you know this book, where force is acting on single tooth restorations. Okay, the force itself could cause a failure because the occlusal contacts would have spoiled. That would have generated a perio. Just remove the crown and you'll see the success in that particular treatment, then reevaluate, revisit, and just do this one. But when it is a primary problem, there are many cases where the tooth is healthy. You'll come across where no caries, but patient has pain. But believe me, there could be something called as retrograde periodontitis. If there is a cusp, there is a prominent buccal cusp, mesiobuccal cusp, which is impinging into the interdental perio area and would have started a perio problem. Because of the widening of the periodontal ligament in the mesial or distal part of the root, the pulp would have got this one. You don't even have to give anesthesia. You can open the tooth. That is called as retrograde pulpitis. So there are many situations. The periodontist and dentist or endodontist don't work together. Each one blames their specialty. Okay. For me, if I ask me in definition, what is endodontics? My job is from orifice to apex. Beyond that is perio. If you damage it, it will give you back. Endodontics is forgiving. Periodontics is not. Be very holistic in your approach. Ensure that you give the lab the work of your crown to an excellent lab. But what I've started doing these days, if my tooth does not, it's a class 1 opening, I don't break my contact. I do a very superficial restoration, which only involves like an onlay, where I don't touch the virgin contacts from the adjacent tooth. All these practices has to start. Otherwise, your endodontics will definitely be a failure, not from the endodontic per se. It will be from the other restorative per se. Thank you.
Thank you, doctor.
Sir,
Thank
calcium
you.
calcium hydroxide for which cases we need to give as temporary dressing and how long we should give?
I don't believe in calcium hydroxide, madam. The reason I don't believe is it is like your antibiotics. It is a alkaline value and it is introduced in the profession in 1920. Corona itself getting Delta variant, that variant, it is, it is kind of becoming super, bug. So don't you think so? Bacterias and whatever bacterias in dentistry is not evolved for calcium hydroxide. They don't die. The alkaline pH don't work. Simply because those days Grossman suggested, because we didn't have other tools and tricks to clean our canals. We just had to depend on chemicals. But now, believe me, I don't use calcium hydroxide, and I've never used calcium hydroxide. The headache with calcium hydroxide, use them, cleaning them is another headache. Okay. If you push calcium hydroxide directly into the periapical area, it causes necrosis. You are not going to use calcium hydroxide from today. You try yourself, you tell me the results. And the other thing is, I don't use antibiotics as well in any of my cases.
Yes, sir. So for periapical pathology and for retreatment cases, will you give any other medications?
No, madam, just wait and watch. 2-visit endodontics, wait and watch. Tell the patient you will have severe pain after my endodontics. Why? I'll tell you, simple logic, I'll explain. The bacteria were going and coming, or if there is an exposure, something was happening. Now the bacteria is getting traffic jam. So what the bacteria has to do something with the periapical. You will have pain, you will have severe pain. I am going to facilitate that pain to come out. How I do that? No antibiotic, simple lukewarm water gargling for 10 times a day. Within the 4th day, I get a sinus opening done in that patient. If there is a periapical lesion, it will immediately, if you seal it coronally, properly, thoroughly, it will try to open up in another way by a sinus opening. I will give you all my patient's detail. You can take this, you tell the patient, educate the patient, antibiotics is not going to help you, just your lukewarm water gargling. You will have pain, painkillers are enough. If there is an excruciating pain, take a IM painkiller, but don't touch antibiotics. Wait and watch. For the problem to cook, it has taken years. For the problem to go, it will take some time. Reassure the patient. You will have great success, man. Believe me. I'm not talking this. I'm talking to all of you with a big forum. I can take this as a challenge and I can show you my cases. None of the cases which I showed you with such periapical big lesions, I have used calcium hydroxide.
Sir, uncontrolled HbA1c is a contraindicated for a root canal treatment. I mean that is severe diabetic case. It's not a contraindication. No, sir.
There's only one contraindication, that is the patient's affordability and doctor's inability. Apart from that, everything is an indication. HB1AC, you might have to cover this patient with antibiotics because their infection, the healing potential, the neutrophil, if you know about the neutrophils and other things, we need this.
Any other participants have any other doubts? Can we
If you can, you can get my contact and we are there to take it up if there's a time delay and other things. So I will share my.
No, sir. You can continue. I think her mic this is not working. Audio is not working. So she's not silent. You can continue, sir. No problem.
So basically, I believe in giving any person who's severely antibiotic has to be given antibiotic coverage, right? Similarly, only you're giving antibiotic coverage for the healing to become better. There is already a compromised healing in a patient who is having diabetes. That's the only thing.
Okay, thank you, sir. Thank you.
So for retreatment cases, will you wait how long, and you will finish every procedure and you will wait for the
I will wait. I'll remove my gutta percha. Okay, for the first visit, as much as possible, explore the canals. I will wait only for 1 week, man. And obturate.
Meantime, what's coronal seal we need to give, sir?
I use glass enamel. I don't use. If you only do a simple experiment in your clinic, man. Just take an extracted tooth, put temporary cotton inside, and put your temporary filling, whatever you use in your clinic, and soak it inside the water. Okay. You take another tooth, you make an access opening, put a cotton, put a glass enamel, what you use, and put it in water. After 1 week, you see which the cotton inside the temporary will be wet. The cotton inside the glass enamel will be dry.
Like from dense ply, they are having the temporary cavity with resin.
Madam, cavity. All these things are not required, madam. How much money will you? There is a cheapest JIZAI available for 500 rupees. Indian made. Don't even, if you think it is expensive to give JIZAI as a temporary filling.
No need for GC brand. No need for GC.
There's nothing like that. There is, even if you use, ma'am, what is your costing? How much money will you lose? You're not going to lose, but your success is going to be assured, no? Anything, a stitch in time saves 9. Nobody told you this because you were thinking temporary filling is easy to remove. Actually, by doing a glass enamel restoration, you're automatically creating a wall also. If there is any wall damage, that wall you don't have to remove. But in a temporary filling, you'll have to rebuild that afterwards. For core building also automatically happens with the same temporary restoration. It's a simple change in the attitude of the approach. At the same time, scientifically looking, see, your oral bacteria is more dangerous than the bacteria within the root canal. Your root canal is actually clean and nice. There are anaerobes. But your oral fluids have aerobes. When the aerobes go inside the anaerobic area, they become obligatory anaerobes, which are more dangerous. That is why your root canal fails. This version nobody would have told you. The reason is nobody thinks, because we only follow what is told by Grossman. Grossman told so many years back. So why are we not adapting to what is happening currently? Any more questions?
So one final
Sir,
question.
please tell me.
Yes, ma'am.
Please tell me the good matrix band, sir, for class 2. Sectional matrix band.
Madam, how much money you want to spend on this? Who told you about matrix band? Now, I'm asking you this question direct to you.
Yeah.
That none of the matrix band used today can give you a good contact like amalgam, because amalgam is the only material which can be condensable and staged. For example, if you, what is matrix band? Matrix band comes from a Latin word called as mater. Mater means mother. Mother holds the baby and gives the form to the baby. So in fact, if a matrix band is holding and not giving a form, as soon as you remove it, the form is different, then you cannot achieve great success. So in my opinion, if you are doing a class 2 restoration, it has to be an inlay and not a direct restoration. The most expensive matrix band, like your Paladin or V3 system or Garrison system, they're all very expensive. Okay, but even after doing that, you are still not able to achieve a good contacts and contour for composite restorations. So what I recommend, if at all, if you're doing a class 2, it has to be an indirect restoration. But just because dentists are not wanting to do indirect composite restoration, the indirect labs are not opened up. You got my point. You can also do an indirect restoration like your ceramic this, but it is expensive for the patient. If you and I tomorrow start telling there has to be an indirect composite system available, it is going to be made available. And that's the best restoration, because the way you get your contacts and contours in a crown, you cannot directly restore. Even I am doing restorative dentistry for, I can show you, I can have another lecture for you to show you those problems there. You can never achieve a good contacts with your existing depths of matrix band, G rings, V rings, that one, this one. Everything is a nonsense. Everything is sold to us just because our Indian scenario doesn't allow us to charge so much. But I'm simply solving your problem by telling, do an indirect restoration. No patient walks inside your clinic with an ideal class 2 like the way we do in our preclinical lab. They all walk to you only when there is cavities are huge and big. By then you can't put a base. Then somebody says protect the pulp. All these things are nice on a textbook. Anybody in this forum can tell me that have you successfully done a good class 2 without having post-operative complications for 5 years? It is possible only with amalgam. Even if you have spilled it all around, your gums are still healthy. But with composite, you will never have a successful restoration for more than 6 months or 1 year or 2 years. So that is a disadvantage of the matricing band system. But the matricing band which I use, if at all, if I have a very small cavity, is from Garrison Dental. Okay, you can go and look at it. It is a nice matrix band with a colored system, color coding. It's got a very, very silicon-based support so that there is no impinging into the gums, and it's also got a nice feather-edged wedge along with that. Thank you, madam.
So one final question, sir. Sir, one final question out of subject, sir. You would have talked to your seniors and you have talked to your professors and all. So for the past 15 days, a lot of patients are coming to our clinic. Sir, I had vaccination before 10 days, before 6 days. Sir, whether what they are telling, sir, whether there will be any cross reactions when we are giving lignocaine with adrenaline with the vaccinated people, what they are telling. So what's your opinion?
See, we had very good question, and I think I should have brought this up. And thanks for bringing doctor. I think we are doctors who have to evolve with the technology. We wanted to publish this article. where patients are commonly coming. If a patient has got a simple swelling and the patient got an vaccinated done, and this swelling is aggravated.
Yes, sir.
So the aggravation of the existing problem is happening. One of the doctor, my own senior doctor colleague, he took his second dose. He had a small stomach infection, but his time was there because of all this crunch. That his stomach infection got aggravated. So what is happening is the first 2 days after vaccination, the immunity drops. If at all, if there is an existing infection, that takes super lead. I don't know about the reaction of xylocaine, but I will tell you there is no reaction of the xylocaine yet reported. Nobody is getting it done. People are staying away. So if somebody is doing that heroism and coming and getting a xylocaine, I would have reported. But what I have seen is that there is a compromised in immune response. The immunity drops for the first 2 days when immediately vaccinated. So what exactly happens is once the immunity drops, it's like as though you have a small infection which just bloats up. So please be careful in this particular point about the immunity coming down. Youngster also, young person. I had one patient who had multiple. Mother is feeding baby, a 1-year-old baby, had a tooth infection. We don't know how to manage. Antibiotics cannot be given. But we tried to manage. We opened up the tooth. We cleaned it up. Still the patient was kept on drug. We didn't push her on antibiotics. But the patient swelling increased. So she had just taken vaccination too. So you're in a dilemma what to do, because you will have to help the patient out of the pain. You know this is happening, which is not normal. Usually this happens in a patient who is diabetic. Doctor asked which an HB1AC, even open up and the next day swelling will be so big. So there is definitely an immune response which is similar to that of what happens in a diabetic individual, where the neutrophils activity is phagocytosis and all those processes. If you know the process of how the neutrophils behave, first they have to move from one year. There are all those things are delayed in a diabetic individual. Same thing could be happening. So what kind of an immune response? I really don't know to explain at this point of time. We have clinically seen many patients who are existing diseases get aggravated.
Okay, sir. Thank you. Thank you, sir.
Any more questions? Doctors, it's been really interactive and I'm sorry about the technical glitch and thank Money Medical for supporting us to help me interact with this great session. Dr. Arasu and Dr. Sujata, thanks again. If there are any questions, my mail ID is displayed, or do we have to take more questions?
I think so. It's almost done, sir. It was a wonderful lecture, and I think so. We are almost very clear with how to do with with all these files and use all these files in our day-to-day practice. I don't think so. We have any other questions. I think Dr. Arul can take over. Dr. Arul?
So this is a wonderful lecture, sir. I think we can have a hands-on with you. That's what I'm suggesting to Money. So
yeah, definitely, Arul. We'll definitely come. I would love to come to Madurai to see the coil.
Please. We are
coil paaka varano. Romba naal aachu.
Kandipa. We are there. We are a good host anyway. Madurai is always a good host, as you know. Yeah. You should please come, sir. Thank you so much for your lecture, sir. And if any doubts is there, members can just contact the doctor. He can display his number. He has displayed his number and email, so you can just contact him. I think sir will explain you in person. Yeah. Thank you, sir. Thank you so much. I thank Mani and team for sponsoring such a wonderful lecture, sir.
Thank you, Arun. Thank you.
Sir, thank you so much.
Thank you so much.
Thank you, sir. Bhubil sir. Thank you, sir. That's fun, sir. Thank you.
Thank you for wonderful lecture. Thank you, doctor.
Thank you, sir.
Vinod,
Thank you, sir.
India. Yeah, fine.
Bhupati sir, thank you. Anala sir, thank you. Sujata ma'am, thank you.
Mr. Shivam.
Welcome, sir. Welcome.
Thank you so much, sir. Mr. Shivam.
My pleasure.
Shivam. We would love to have Dr. Vinod. We would love to see you in Madurai.
Thank you so much. I will definitely come, and thank you for all your gestures. Hope I have answered your questions, but I also want you to try whatever I told you, because ultimately we are all here to help our patients, and we serve this society and our country in a better way. Thank you all.
Thank you.
So
Thank you,
thank
Dr.
you,
Vinod.
thank you everyone from Team Money. We thank all the attendees for their patience and time today, and thank you to the entire team of IDA for their help and support. And top of all, thanks to Dr. Vinod for being so patient with us today. We and getting this session conducted in such a wonderful manner and answering so many questions. So just a small token of appreciation from
Thank you.
our end, a certificate of appreciation. We'll be mailing this to you over an email also. And
Thank you.
we have already posted a feedback link on the chat of this webinar. I would request all the attendees to please do share your feedback in that link. We'll be sharing that on the group also. So please do, and soon we will be preparing the e-certificates for all the registered participants, and it will be shared soon. So thank you everyone, and be safe, be healthy, and enjoy Endo. Thank you.
Thank you. Thank you
Thank
all.
you.
Bye-bye. Bye.
Bye, sir. Thank you,
Bye.
sir. Thank you. So, Shivam, can we just log out?
Yes, sir,
Yes,
you can
I'm
log out.
taking it.
Yes.
Sure, sure. Thank you so much. Thank you, Mr. Ramajayam. Thank you.
Thank you, sir. Thank you so much.
Thank you, Mr. Shivam and Mr. Ramajayam.
Thank you, ma'am.
Thank you, ma'am. Thank you.